support. Righto, good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. As we are about to set off one of the most scintillating, what promises to be one of the most scintillating sessions of AIOC 2021. As has been already introduced to you, this is a debate, this is a duel. So we have a stellar cast to fight it out. We have all the Dumbledores and the Voldemorts having their wands at the ready to attack and counterattack each other. Admin, every presentation has a max limit of time of 3 minutes, and that will be followed by a panel discussion, or not a discussion exactly, a panel opinion, which would be for 2 minutes. So set the time accordingly, please. To do the honors with me, I have Dr. Sneha Batra, who belongs to the land of Goddess Durga. Sneha, please say hello to your audience. As has been mentioned already, you muted, Sneha.
Am I audible now?
Yes, you are, loud and clear.
So, good afternoon and welcome everyone.
So as has been said to everybody already, she is the one who conceptualized this idea. She's the one who moved it forward, who chastened it forward. And I've always been jealous of Dr. Partha Biswas at the kind of selection he has to choose his colleagues. It's been really wonderful working with you, Sneha. Thank you so much. Right then, I would not come in between you and the session anymore. Let's move on to the first motion. Sagar, you need to share your screen. The first motion is, we know that the cult in the present day scenario for ophthalmology practice is private practice. Everybody wants to join in private practice or initiate a private practice. So the motion here is group cataract surgery practice better than solo practice? Coming in to speak for the motion, we have Dr. Sagar Bhargava from downtown Kolkata. He has established one of the co-founders of a beautiful hospital called Netralayam. I've had the privilege to visit it. Sagar, you ready? Your time starts now.
Good afternoon, everybody. I'm going to speak for the motion. So let's get going. So before I start my presentation, let me give you a small example of a young doctor who joins a group practice, advises his first cataract surgery, and then the patient goes through an array of state-of diagnostics handled by highly trained staff, then lands up in OT with state-of-the-art OT with best of microscopes, best of phacoemulsification systems, and if it all required, digital imaging system also. The patient outcome has been very good. Doctor is very happy, and patient then brings in more patient, and Juggernaut starts. Now remember, this has been achieved without investing a single rupee. And imagine the same doctor going solo in today's time. It'll take definitely a few years before he reaches to this level of eye care. Now imagine the second scenario. This doctor completes about 5 years of practice, gets an opportunity to invest in similar model and create another facility. Now the earning continues from the practice, and in the long run, he benefits from the profit of the center. What I just described, in short, was actually my story, which started in 2014 when I joined this BVI group of hospitals in Kolkata. And in 2021, I had a privilege of being one of the investors in this wonderful group practice called as Netralayam. So what makes this model work? So time, as we all know, is the most valuable resource which is at us, available to us. So every minute counts. The moment I enter the hospital from 9 o'clock to 6 o'clock, every minute goes in the patient care. And that helps in improving efficiency as well as the focus on the patients. And this I can do because I don't have to get into all these activities of running the hospital. Again, because I work in a group, the clinical skill upgrade is much faster than others, because one of the doctors in the group may get some new information he will share, and we will implement that. Of course, I can take n number of names as I want. The center will keep running because there are other people who take care. And with combined volumes of all the doctors are there, we get a better negotiation power with the company, and ultimately we get instruments at a better rate. And aggravate of all the patients, ultimately leads to a much faster brand establishment, as we have seen in last 10 years of these two brands. Now, this has really resulted in a good increase in OPD numbers for me personally over a period of last 5 years, except last year, of course, everybody knows it's the COVID time, and and as well as the OT numbers. So in the end, I would like to ask you, which practice graph will you prefer? A graph which is slow to start with, and most of the practical life goes in waiting for success, and once the success comes, you are at an age when you look at your children to take over, or you want a graph like this where the success comes very early in life, and you become financially independent. You can do things other than your practice, And I would any day pick up this graph. This is an exponential graph which we see in group practice versus this logarithmic graph which we see in solo practice. I thank you for your attention.
And I thank you, Sagar, for not being close to me right at this moment. Right, so Sagar says, excerpts from his presentation. A, your hair is going to gray. Dr. Marine, if you're still there, please start sharing your screen, ma'am. So I think you heard him. He said your hair is going to gray or possibly going to fall by the time you catch attention of the society. You're going to get into all sort of mud by not getting into exceptional clinical practice and exclusive clinical practice. You are going to get yourself involved in a lot of other activities. And number three, perhaps the most important thing, is that it's going to take an eternity, and he's going to choose a curve which will give him success in a flash. Coming from south, down south from Kerala, Dr. Marine Paul is going to counter that in the next. You are audible, ma'am.
Thank you.
You are going to present and counter these points which have been very well put up by Dr. Sagar. Ma'am, your time starts now.
Thank you, Dr. AIOS and Dr. Sneha for having me here. And my position is that yes, flying solo is the better thing, because the good thing about flying solo is that it is not boring. Now, let me give you a little bit of perspective. When the idea of group practice started in US in early 1930s, they started ringing the death knell of group solo practice. But believe me, gentlemen, ladies and gentlemen, even today, 17% of practitioners in US are solo practitioners and flourishing. See, this model works in a very heavily in insurance-dependent markets where, yes, group practice works. But in India, where 70% of our population is rural or semi-urban, this model is not probably the best thing to latch on to. Basically, we are doing copycat models, yes, because Dr. Sagar is in a city, yes, it works for him. Now, at the beginning, let me make a disclaimer. This solo practice is not for people who are not independent-minded, who are strong-willed or not willing to take up challenges and are not financially literate. If you are in this segment of people, please go ahead, join the nearest group practice. Now, there is this myth that there is a huge financial outlay, no growth, no time for self. But the truth, as always, is somewhere in between. Yes, that graph he showed, so it showed a slower growth. But you own it. You are the one who controls the narrative. If you want a higher growth, you can invest. It is not that loans and the other financial instruments are not available. Now, the most important thing, why are we doctors? We like to connect with our patients, and personalized patient care, ladies and gentlemen, will not come in a group practice. Unless you are solo, you will not have that connect with your patients, which spread across the generations. You have absolute control over the way your practice grows, and you control the narrative. And in situations like this, where there can be adverse circumstances like the COVID, you have much more flexibility and you will be able to pivot so much more faster in these circumstances. Imagine having to go to a group of people and, chalking out policies, and all this takes so much time. And coming to work-life balance, that is an attitude, and it's a whole talk on itself. And believe me, you can have fantastic work-life balance if you do it the right way. Now, let us talk finance. If you're a cataract surgeon and you're in a group practice, you're cross-subsidizing all those expensive specialties like retina and all the others. When you are actually the engine or the driver which keeps the whole thing going. So why do you want to use your sweat equity to grow an entirely, whole different segments when you can do it for yourself? If played right, you can have plenty of tax advantages and you can keep your overheads low. So like Dr. Sagar said, if you are a founder, yes, definitely group practice can be good. But remember, if you're a junior and joining a group practice, tell me which of the juniors have really become a great practitioner from being in a group practice. They all eventually branch off to found their own. So remember, as George Orwell said, all animals are equal, but some animals are more equal than others. Now you decide which animal you want to be. Thank you.
Thank you so much, ma'am. That was two excellent discussion and two very strong opinion put up by some of the stalwarts of our field. And let me tell you, we young ophthalmologists are totally confused now. So to help us solve this confusion, we are going to have an expert opinion from Dr. Ashok Rangarajan. He is glaucoma and retina specialist practicing at Apollo Spectra Hospitals, Chennai. Sir, over to you.
Thank you very much, Dr. Sneha and Dr. Anurag. Now, I'll quickly summarize. So the group practice, Dr. Sagar did put across his points very well, but it's very important about who is the group. I mean, what is the group? Do you gel mentally and will you gel on your way forward with the group is what is important. Not everybody achieves to get that group of like-minded people, and going forward, giving the direction and growth pattern. I believe in one thing, even within the group, there has to be one head, because if there are 4 or 5 or 10 your group, all of them taking decisions, then it's going to fall apart. This is one. The second thing is the location. Like Dr. Marine put rightly across, you cannot get the group practice kind of a group of people and evolve that in a smaller town or in a slightly more Mufasal area. Third is today finance is available for the group or for the single. So that should not scare a person who should put his foot forward. What is important here is how much self-confidence do you have in yourself to start a practice, and what strength of risk can you take by way of taking loan and in the location that you're putting forth your practice to put in your own finances or take a loan and start your practice. So this is a balance and a decision each individual would have to take. And third and very important, and the other important thing is you should not hesitate to pull out if you feel the group is not carrying forward the basic principle with which you started the practice to start with. If anybody else wishes to make a comment, Dr. Anurag.
You might just look at that after the whole session's over, sir, but points very well taken. I think you've summarized it very well. There was a good consensus between the two speakers. Interesting to note that, and both of them agreed on one point. It does take time to establish yourself in solo practice, and it does take a bit to manage your finances as well in solo practice. It all depends on you, whether you can manage it or not. So Dr. Ashok, if the right hand is for Sagar and the left hand is for Dr. Marine, which hand is going to raise up?
Right. I would think today's world, it's better not to take the financial stress. There is one point I do agree, ophthalmology being a very high investment and today technology being a thing. Let me, before I make this final comment, let me tell you that I have a single practice. I own a private limited eye hospital in Chennai, and I've been for the past 6 years with it. And it's like solo practice for me. So yes, I do understand sometimes that you want somebody else also to share the burden or take the stress off your head. But yes, I agree with Dr. Marine here that there is a separate level of satisfaction. But should you give me a choice between the two, I would probably think putting like-minded people together brings the investment better and decreases the risk potential. So it will always help in today's world to get together.
Thank you so much, Dr. Ashok. Thank you so much. You really summarized it well. Right, ladies and gentlemen, time to move on to the next motion. This time the duel is going to be all Maharashtra. The Dumbledore and the Voldemort both belonging to the same soil. The motion here is, should a pure vitreoretina surgeon, a trained vitreoretina surgeon, be doing cataract surgery at all? So the motion is, a trained vitreoretina surgeon should never ever do cataract surgery. Dr. Alay, please start sharing your screen. Dr. Alay Bankar is the one who is going to speak for the motion. Dr. Alay, if you're ready, the clock starts ticking for you now. We can't hear you, sir.
A trained VR surgeon should never do cataract surgeries. And I'm going to speak for the motion. What I feel that I have very important disclaimers before I start my presentation. And the first is our esteemed scientific committee chairman, my very dear friend and my co-VR fellow from Shankar Netralaya, Partha, who actually deserted us and became a true cataract LASIK surgeon. I also have my mentors, Dr. Abhay Vasauda and Dr. Steve Charles, who have given me ideas on why a VR surgeon should never do cataract surgeries. And of course, myself, who have never done a cataract surgery since I've passed my MS in October 1993. So let's see a few points. I think when it comes to a VR surgeon and a cataract surgery, and when you're talking about cataract surgery, it should be classical. The patient selection and assessment is a paramount factor for the success of a cataract surgeries. VR setup might not have all the equipments required for a very classic detailed preoperative evaluations. And I've listed all the things where a classic standard cataract surgeon does. And this is almost impossible if you have a VR practice and are doing cataract surgeries here and there. Yes, if you have a partner who's doing a cataract surgery, you might have this, but being only vitreoretinal surgeon and doing cataract surgeries, I think it is almost impossible to have all these instruments to have a great preoperative assessment. Coming to the surgical parts, you should have very good anterior segment console and all the instrument and accessories and the different types of OVDs and IOLs. And we know now cataract surgery has become a very, very good expert, and you need different kinds of things for different situations and preoperative situations where you expect like mydriasis or a floppy syndrome or anterior synechias. And then you have the technique itself, the various kinds of incisions, capsular X's, IOLs, and you should be aware of all these if you're a trained VR surgeon, if you're going to do a good cataract surgery. Also, we all know in literature, all VR surgeons and who do cataract surgeries, they have a high incidence of postoperative inflammation. And I think the most important factor is how you postoperative counsel a cataract patient, which is very different from how you counsel a VR patient. So the VR surgeon might be confused when he's going to counsel the cataract patient he's doing. And lastly, I think it is advantageous to know a cataract surgery. However, if you are Dr. Dudani, my opponent, who is an extremely good friend and who is a great pan-ophthalmologist who does cataracts, LASIKs, DCIs, everything, I'm sure he can do it. But for a pure VR surgeon, one should never do cataract surgeries. Thank you, sir.
You can stop sharing your screen now. So the last statement perhaps was an attempt for Dr. Deepak Dudani to go soft on him. Dr. Dudani has started his screen sharing. I think there are two aspects of becoming a cataract surgeon. One is cataract surgeon, one is contrivances, and the other is skills. Dr. Alay says that in both you fall short if you do not stick to your segment. Handing over to omni-segment surgeon now, Dr. Ajay Dudani, Professor Ajay Dudani, to speak against the motion. Your 180 seconds start now, sir.
Yeah, so thank you very much, Alay Banker. I'll be saying that trained VR surgeons should always do cataract surgery. A VR surgeon should never do cataract surgery. What are you saying? I mean, this is my paper, this AIOS, which I had a free paper here. This was last year, and this was the year before that. So I don't want to be a fortune teller and see the future that maybe sometimes my retina patient will have some vision. I want my patient to see today and now. That's why I'm an eye surgeon. So see, the biggest chunk is cataract in my OPD. And we are all friends. We are retinal surgeons, cataract surgeons, pediatric ophthalmologists, and we studied together. So why shouldn't we don't we have nimble hands, keen eyes, foot control, and a never say die attitude, and loads of patience and patience. And fastest finger first works everywhere, in cataract and in retina. And all cases, we have seen these cliffhanger cases, we are the best to treat, the Yamane technique. So I think there's a merging of both these things, and the ship sinking where they send us these patients, we can handle them. So why not handle a straight cataract when you're such a good surgeon, you know? Why you need to drop it and then do it? If you can be friends to your retina friends, why can't your retina friends be your friends also? So, qui el mangent de la brioche, that was said by Marie Antoinette. Why leave bread and butter and just eat cake of retinal surgery? Cataract surgery is a piece of cake, which like vitreoretinal surgery, you don't need to bake. And for God's sake, so there is nothing new except what has been forgotten. So you've never forgotten your cataract. So what's the bright side? You have good income and best outcome. At least some of your patients in your OPD will be seeing, for God's sake. You're the best for subluxated cataract. Do LASIK at best as well. You can scrape corneas in VR surgery. Let them see. It's now or never, unlike VR. So I started with ICC, then I moved to phaco, and today I'm trained in retina and fellow and phaco, so I can do a pole-to-pole surgery. So we get referrals of drop nuclei, dropped IOLs. If I have a Porsche, why just use the posterior segment in that? I have a very beautiful anterior or combined segment in my machine. And cataract attracts a VR surgeon because you have the same stripes, as you can see. Combined surgery is a must today in retina surgery with macular hole, with ERM, with vitreous hemorrhage. So you need to do your cataracts yourself. You can't wait for your anterior segment surgeon to, show you tantrums and so not now, not today, So just clear your media, get rid of the cataract for good view. But today's era, premium cataract surgery, my friend said, I only do monofocals. Show me one cataract surgeon who has a multifocal in his eye, and I will bet with you. So I do a toric, and it's a kid's play for me. The typical history of an RD patient, I'll tell you. Pre-op, his vision is PL. Vitrectomy with gas. Post-op, he is PL because he has gas. 1 month later, he's redetached. So he's never seen. So you have an unhappy patient, OPD. So let's have some happy patients in our OPD and let us do well. The advantages of VR fellowship shortens the phaco learning curve. You have bimanual dexterity. So thank you. Thanks for letting me do cataracts. It's my birthright. I'll fight for it with my phaco till my last piece is emulsified and a single piece foldable hydrophobic toric lens is inserted in the bag with a swag. Thank you so much.
So this debate gets more and more interesting with two heavyweight VR surgeons in the ring right now, and with discussing an age-old topic which has always divided vitreoretina surgeons all over the world. So to give us a final conclusion to this, we have none other than Dr. K.S. Kumar, who has not one but 3 VR fellowships from Shankar Nethralaya, Nagoya National Hospital, and UW Medicine. So, sir, tell us what is your opinion regarding this?
Thank you so much. I would like to start off by dissecting the very topic of discussion. First of all, the dictum in life would be never say never. So you may have to eat your words, so never say never. The second point, the definition of trained, according to the dictionary, is developed or improved through instruction or practice. Very simple. So what prevents a vitreoretinal surgeon from developing or improving his cataract development skills, either by instruction or by practice? That need not necessarily be training elsewhere. He can train himself. So there is nothing. So that is the perspective with regards to the topic itself. But having said that, I would like to say that if you are looking at cataract as a refractive surgery and you're solo in practice and you have cataract surgeons all around you who are doing premium IOLs and only cataract surgeries, then you might be at a disadvantage. But if you're in a group practice and if you have to do a cataract plus vitrectomy combined, I tell you, I quote one instance. I had a surgery where the cataract and vitrectomy had to be done. The anterior segment surgeon did the cataract surgery. At the end of it, the wound was leaking. He was having an ego problem suturing it. He hydrated the wound. The superior hemicornea was fully hydrated. And he said, now the wound is airtight. Go ahead and do your vitrectomy. This was a genuine situation. Now, these kind of problems can happen. So if you have the necessary skills to do a decent cataract surgery, which will come in handy when you want to do it, along with the vitrectomy that you have to do, that will be useful. To put it very loosely, you cannot say that a taxi driver cannot drive an auto rickshaw. If he is good at both, then he should be allowed to drive if he has a proper license.
Thank you so much, sir. If the time allows, can we have one more small comment from our other VR surgeon in the panel?
Certainly, Sneha.
Dr. Gajendra Chawla, sir, are you there?
Yes. I'm very
Yes,
here, and it was very interesting talk, very interestingly presented and summarized by Dr. K.S. Kumar. But yes, I also feel if a VR surgeon can do a cataract surgery, he should be allowed at least because of this. What Dr. Kumar says, yes, sometimes we have to do a phaco-vitrectomy combined surgery, so we should not depend on the cataract surgeon because of his availability, his appointment, his everything. So if even I'm a solo practitioner, if I have to do a phaco-vitrectomy combined, if I'm not doing cataract surgery, I have to ask someone to come and adjust his time, my time, and so many hurdles. So phaco-vitrectomy, yes, definitely require. And yes, Dr. Alay says, yes, for premium IOL, maybe you have to have all equipment what he has mentioned. But otherwise, if he can do a surgery, my opinion is he should do it.
2 thumbs up for VR surgeons doing cataract surgeries. Over to the next topic, sir.
Yeah, but before that, just extracting the last couple of lines from Professor Ajay. In the bag with a swag, Professor Ajay, you are a Vitro-Retina stag. And here is a clap for such a wonderful, wonderful presentation.
Thank you,
Thank
sir.
you
Thank
so
you so
much.
much.
It was
Thank you.
really,
Thank you.
really enjoyable. Thank you so much.
Thank you.
Right. So, Sneha, you can ventilate this to Dr. Partha Biswas that not everybody is happy with him for switching his segments. Right?
Absolutely. I've taken a screenshot of that, sir.
True. Right. So moving on to the next motion. And the next motion is cataract surgeon. It's related to the one that we've just discussed. Cataract surgeons should never ever do medical retina. And we will reverse the order slightly in this. We would invite the speaker who is going to speak against this motion. She is none other than our very own Dr. Bharti Kashyap from Ranchi, Jharkhand. Ma'am, please start sharing your screen. Nothing to introduce her. She is going to electrify this whole session, I'm sure. And if it does any help to the flow of ma'am's talk, ma'am, can you please start sharing your screen if you're there?
Doing.
Yes. So I'm very wary of Dr. Bharti's presence all around because she's already defeated me once in a debate back in 2014, if I remember right. So ma'am, are you ready? Here goes the...
Am I audible?
Absolutely audible, ma'am. There cannot be a situation where you're not audible.
Okay.
Your time starts now, ma'am.
Okay. So good morning, everyone. My topic is cataract surgeon should never do medical retina, against the motion. Yes, of course. Every cataract surgeon, not only the cataract surgeon, must do medical retina. What does the law say? See the MCI guidelines to the various institutions having ophthalmology. The format for practical clearly shows that 70 marks out of 150 are for retina cases, and they must know intravitreal injections. MCI has made medical retina teaching mandatory for all postgraduate students. The degree is not only meant for decorating the walls of your clinic, but to be of use to common public. If not medical retina, they should not be allowed to handle even other subspecialties. In our country, more than 18% is contributed by diabetic retinopathy and AMD. Leave aside other retinal diseases. We need to screen 5 million babies per year for ROP, 65 million elderly for AMD, and more than 80 million diabetics for diabetic retinopathy. Out of this 80 million diabetics, 20% of these have some form of retinal involvement warranting treatment. These are the various studies quoting the same. About 30% of the cataract patients have AMD at the time of cataract surgery. See the other retinal comorbidities with cataract as shown in this table. Can 1200 VR surgeons handle just one of the diseases among ROP, diabetic retinopathy, and AMD alone? Leave apart the cumulative load. It is a big no. 70% of our population is in rural area, while 30% of doctors are in rural area. Availability of VR surgeon in rural area, almost zero. So it means these all patients have to travel so far. More than 80% of travel of the rural population is for medical reason. Do you really want the rural to suffer that much? So look at the India's poverty profile. 1/5 of Indians are poor. That is almost 27 crores. 75% of them earn less than 5,000 rupees per month. Can they afford all these VR surgery costs? It is not only the procedure cost, traveling time, lost working hours, accompanying person stay. In case of emergency, like endophthalmitis, just delay because of the travel time would mean a panophthalmitis. Women in the West, when in Western world, OR nurse can inject intravitreal injection. Why not at least we anterior segment in our country, in India, we can do it. We need to learn from this pandemic. Big hospitals meant for cardiac and other specialties were converted into COVID center. See, we doctors, forgetting the barrier of specialty, stood up to the challenge of pandemic and treated COVID patients with otherwise in the domain of specialists. Right from the medical intern to head of the department rose up to the occasion. So think beyond self and let others distribute your work. Thank you.
Thank you so much, ma'am. It would have been really interesting to find out how this vibrant presentation was going to be countered. But unfortunately, I mean, this probably with a query mark might make you happy, Bharti ma'am, but Dr. Mamta Agarwal, who was supposed to speak for the motion, has not been keeping well. So she pulled out, and we learned about this morning. So we did not have any time to arrange for an alternative. The onus was on me to speak for the motion, but I said not the second time. Definitely not. I'm not going to lose to her again. So Sneha, I think we would just take an extended panelist view on this, and let's see what the panelist has to offer as an opinion for or against. Dr. Bharti is definitely visibly happy. So over to you.
I wish her good health.
I know.
I wish her good health.
I know, ma'am. I know.
Yes,
It was just in light of it, right? Yeah.
Indeed, a topic which has divided a lot of cataract surgeons, and medical retina is soon becoming the go-to field for all cataract surgeons to add to their armamentarium. We will take a quick opinion here from Dr. Sahiba Sethi, who is a glaucoma specialist, but we want to know medical retina, is it the right of every cataract surgeon in today's world?
Thank you, Dr. Sneha. There were very interesting points put by Dr. Bharti. But in my personal opinion, it's not so much about what you can or cannot do, but it has a lot to do about where you were trained, how you were trained, and also where you live, the demographics of your area. So I think in a rural setting, it makes sense for anterior segment surgeons to divulge into posterior segment limited, whether it's medical retina, lasers, intravitreal injections, because for them, demographically, for the patients to probably travel so far, if your vitreoretinal surgeon is about, say, an hour away and visits you just once or twice a week, it probably makes sense to learn that skill and give the patient immediate attention when required. On the other hand, in an urban setting, I don't think it will be feasible, because with the kind of expectations patients come with and the state-of-the-art treatments that you want to deliver to your patients also, having a VR surgeon or a trained medical retina right next door, I think you would want to ask yourself again whether you really want to take up their job if you're not trained well in it. But I think the one advantage of doing anterior segment and medical retina together would be the fact that you're not putting all your eggs in one basket. So, tomorrow if, say, cataract surgery runs out of business, when there are drops invented which do away with cataract surgeries altogether, or if you're just a LASIK surgeon and a new procedure replaces it, then what do you do? So if you do little bit of everything and you do it well, then maybe you're better off doing it. But at the same time, you have to have very good relationships with your VR surgeon, because if something goes beyond your skill and you can't handle it, then you have to have them on board. And I think also a lot has to do with the training, and people who were probably trained in the 90s, they are a lot more comfortable in dealing with so much more, because they were trained such. And nowadays our postgraduate programs don't really train you in giving lasers or intravitreal injections, no matter what you say. So, especially going ahead and doing a medical retina fellowship just so that you're able to equip yourself with all those skills probably makes sense in a rural setting. Yes, of course.
Thank you so much, Dr. Sahiba. If we can take one more quick opinion, Dr. Bharti has asked a very important question here. With the increasing load of medical retina disorders in India, can our VR surgeons alone handle it without the help of cataract surgeons? Dr. Ashok Rangarajan, can we have your opinion on this, please?
Thank you for calling me in. Again, personally, I did an anterior segment fellowship and then was trained in medical retina in Shankar Netralaya, where I was in the retina department before I quit Shankar Netralaya. So I'm a trained medical retina person. Now, the opinion here which I have is, it's not about whether a cataract surgeon can give an intravitreal injection or not. That is not medical retina. I feel anybody who wishes to claim himself to be a medical retina consultant should be trained in the practice of examination and interpretation of the various investigations of retinal disorders, and know and not hesitate to take a second opinion when required. Yes, so thereby the need of the country is that all ophthalmologists have to chip in. But that is where probably we are solving that problem by doing teleophthalmology and artificial intelligence where we are able to do all these imaging and have less number of trained ophthalmologists screening for those patients to solve that problem which Dr. Bharti raised. But the important take-home message here is, should only vitreoretinal consultants do? No, there is a subspecialty branch. Let me also tell you that any vitreoretina consultant, if you look at his practice, who is not doing other specialties, is doing majority work is medical retina. So only a smaller fraction of the retinal practice is surgical retina practice. So the need for medical retina specialists are more, but let everybody who's interested get properly trained in respective centers in their region and then practice. And more important than that is not hesitate to take a second opinion as and when required.
Once again, hitting the bullseye, Dr. Ashok, exactly what I had in mind. I mean, if you cannot treat, at least can diagnose, look at the retina, so nobody stops you from there. Righto, moving on, coming to the fourth motion of the afternoon. As you can see, Dr. Jeevan Ladi has already started sharing his screen. The motion is going to be very interesting, and I have a sense that there are going to be more takers against this motion than for it. The motion is, every cataract surgeon, mind my words, every cataract surgeon needs to upgrade to femtolaser assisted cataract surgery. It's once again going to be an all Maharashtra battle. Coming in from Pune, Maharashtra, Dr. Jeevan Ladi, opening statement for the motion. Dr. Ladi, your time starts now.
Yeah, it's for the flax. There's a less rate of complications. There is smooth learning curve. Post-op within 0.5 diopters, flax is 94.2%, while phaco is 83%. Post-op vision 6/6 or better, flax is 53.2%, while phaco is 28.1%. Scan capsular mode, that is which gives a better effective lens position, which is a unique feature of flax and which is not feasible to human eyes or human technique. Correction of astigmatism by laser arcuate incision gives a better and greater precision. There's reduced ultrasound time, so less damage to the endothelial cells. Beneficial in hard cataract, pseudoexfoliation, shallow antechamber, floppy iris syndrome, intermittent cataract, posterior polar cataract, and primary posterior capsular excess. Showing the case of a small pupil. Now this is a small pupil, and you can see that rhexis is small to start with. The pupil, what you see is a little bit more bigger after the suction, but it was smaller to start with. So we make a rhexis which is 1 millimeter less than the pupillary size. Now, ideally, if you would have been doing this cataract surgery in different setup, like only phaco, you would have had to use retractors to dilate the pupil according to your choice. But as you can see here, it can be done very safely without any damage to the surrounding tissue. So results are very gratifying and they are great. You can put a lens in the bag, do cortical aspiration peacefully. As you can see, that bag is lens is going in the bag. Now you remove the viscoelastic from the front side, and in spite of pupil being small, you can still go behind and remove the viscoelastic from the bag. Now, this is one cataract, where you have problems either with SICS or phaco also. This is a hard cataract, so much so that you can see calcification during the sectioning with the laser. This is a capsule which is being removed. And the most interesting part to be seen here is that though we are removing the cataract, when we came to the last piece, we realized that there is a PC tear with a fibrosis around, which would have been missed with the phaco and would have had a nucleus drop. As you can see here, that was the hole. Now lens is sitting well, which wouldn't have been possible with a normal phaco. Now, when phaco came in India in early 90s, nobody thought that it will go to the charitable or government institute, but today almost everybody has it. So I'm sure flax will be there in all sectors. Thank you.
Thank you so much, Dr. Ladi. 28% of post-phaco patients achieve a vision of 6/6, Dr. Ladi says. Primary posterior capsular rhexis is a very effective way of doing it. Flax maybe, but you have to dock the patient twice for getting the job done, and you have to waste 2 patient interfaces, PIs, for the purpose. Anyways, I think Dr. Pankaj Shah, who is the next speaker against the motion, must have taken note of these and all those points he has made. Over to Dr. Pankaj Shah for speaking against the motion. Big Ben starts moving for you now, sir.
Yeah, good afternoon. Is my screen visible?
Absolutely, sir. Please
Thank
go.
you. Yeah, I will speak against the motion. Let us see various contraindications where flags cannot be approached, like small palpable aperture, neck and back problems, which has optimal docking, imaging, and laser delivery is needed for the patient to lie flat. There are patients of nystagmus and attention deficit disorders where they cannot comply with the instructions properly. Even glaucoma is a concern where we have rise in intraocular pressure in flags. Again, corneal opacities hinders in the imaging. There are various subluxated, dislocated lenses where flags cannot be possible because of the liquefied lens material, which hinders laser penetration. Small pupils is a relative contraindication. You cannot use pupil expanding devices. So again, there are many disadvantages to flags as it is expensive, cost is passed to the patient, value is added, there is increased complexity, increased duration. No evidence as yet that increased predictability, which is expensive, complex, longer procedure provides actually delivers clinically superior result over current techniques. Again, when there are increased expectation because of more expensive procedure, operating room shifting of the patient is an inconvenience. Again, becoming too reliant on technology, the fear is that we lose to perform on a higher level when technology is not present. So the importance of surgeon maintaining their manual surgical techniques in the event that they do not have the resource of femtolaser because of the technology. Again, there are various advantages like photo disruption, increased difficulties in the flap if retreatment is needed. Again, multitude of studies have proven that flags need not be superior to manual phaco. Visual benefits of flags over and above manual phaco needs to be conclusively demonstrated. The most common disadvantage is anterior capsular tear, which is most common intraoperative complication. There can be postage stamp perforations. There is an increased incidence of learning curve, increased incidence of prostaglandin levels. Also, it leads to increase in the volume and pressure. There are chances of posterior capsule tear. Also, small rhexis and surgeon's level of experience during fragmentation of the cataract is also one of the factors. So the concerns are flags was designed to improve safety and efficacy to replace highly trained surgeons with lesser skilled technicians. Critical factor of surgical judgment and experience simply cannot be coded into laser software. Flags may allow less experienced surgeons to obtain better results, but fail to demonstrate significant improvement for experienced cataract surgeon not implanting premium IOLs. If you remember, Big B, who recently underwent flags, had also tweeted that the sight and recovery is slow and difficult, so there are typing errors which are to be excused. The Kabhi Khushi Kabhi Gham actor said that he felt like Gary Sobers and seeing 3 letters for each word. So flags, if you go for the ECRS study, worse postoperative visual acuity, more postoperative complications, and likely to have postoperative visual worse than the pre-op. The real danger is not what computer will think like man, but that men will begin to think like computers. Thank you.
Thank you very much, sir. So a couple of decades back, cataract surgeons would have been debating, does every cataract surgeon need to upgrade to phaco? So today, probably we have the answer to that. But the question today is flags going to be the new phaco? Whether that's a yes or a no, and if no, why not? To discuss this, we have Dr. Anand Parthasarathy with us. He's the Chief Surgeon of the Center for Vision and Eye Surgery, Chennai, and a specialist in cataract, cornea, and refractive surgery. We have your opinion on this, sir.
Thanks, Anurag and Sneha, for organizing this. I feel knowing Dr. Jeevan Lani and seeing Pankaj's presentation, I really benefit from having that technology for, let's say, a patient who has a fairly very intumescent cataract, a subluxated lens, and a very small percentage of pediatric cataracts who would benefit from that. In terms of Dr. Pankaj's presentation, I would agree with broad points that he's mentioned, but for a person who can afford it, it becomes a one-upmanship, and definitely in terms of improving outcomes. Now, in terms of data, I don't think there's much to support flags. There are studies, and I always kind of follow European studies purely from the for their ability to honestly present results. So if I look at results and I look at ESCRS study, I would go with their findings. That's all I like to add.
Thank you so much, sir. Can we also have a quick comment from Dr. Santosh Bhire, sir? The flax, the next generation technology is already here, but is India ready for the technology yet, sir?
To Dr. Sneha and Dr. Anurag for a nice debate. In fact, both the speakers are good friend of mine, and both the speakers have given a nice talk.
They're not listening, sir. Go
on. See, flax has definite advantages in certain situations like posterior polar cataract, in subluxated lenses. Yes, you need flax. But do we need flax in all the cases? Do all surgeons need flax? That's the real question. See, there is some concept like return on investment, which is never taught to us. See, economics is never taught in our medical school. So there is concept of return on investment. How much you are going to invest to buy a flax machine and how much returns you are going to get. And like my friend Dr. Anand Parthasarthi has said very nicely, a surgeon who can afford flax doesn't need flax because he is so skillful and he has good set of patients. But definitely for certain cases, if you have flax, especially for posterior polar cataracts, it is of definitely help. Also for subluxated lenses to perform capsulorhexis, it is definitely useful. So personally, right now, we are not in a position that everybody should have flax. I would say that everybody should have a good phaco machine and everybody should be a comprehensive cataract surgeon. He should be expert in both the ways of surgeries, phaco as well as small incision cataract surgery. So my take home message will be not everybody will require flax right now. Thank you once again.
Right. I don't think we need to do the left hand, right hand thing here. So we probably know the vibes before they come out in the open. Thank you so much, Dr. Santosh, Dr. Anand, for nicely summarizing this section of the debate. Moving on to the next motion. Once again, there is a duel between segments. And the motion is, should scleral fixated IOLs / secondary IOLs remain as a pure domain of retina vitreoretinal surgeons? Speaking for the motion is Dr. Manoj Saswade from Aurangabad, Maharashtra. Dr. Manoj, if you're ready, we can see your screen. Off you go now.
Good afternoon, everyone. I will be speaking in favor of SFIs will be remain in the domain of VR surgeons. Any VR surgeon or any surgeon should follow some basic thumb rules that they are very pertinent to the SFIL particularly. Even though it is a 2-point fixations or 200 rupees surgery, I will say that it requires almost 2 hours skills which are acquired by the surgeon. First thumb rule is that the best surgeon should know when to stop and when to use its knife. If you don't have any armamentarium, you don't wait for a proper help. If you are should not do the experiments in a panic state. Commitment of the surgeon should be to the vision and not to the IOL. Consider every patient is your own beloved one. Have thorough training under expert and then start doing some new procedures. Otherwise, leave it to the others. And in such situations, honesty pays, and there won't be any bad publicity about you. Next slide. These are the cases where they are properly sent by the anterior segment surgeon to the VR surgeons. Here you can see that they are sent they stop at proper time and handed it over to the surgeon. Otherwise, if you start experiment in a panic state, you can always create an accident. Here you can see that the lens has been fallen and there are no haptics to come out also. This is the case where the vitreous is in the anterior chamber and it requires a VR surgeon to do the good job. You know that now my opponent, Dr. Shakil Singh, is the expert in a phaco surgeon, but now after PC rent and drop nucleus, it is no more a phaco 15 minutes phaco surgeon. It requires a professional driver on the road which are less driven. And this professional drivers almost take 1.5 years VR fellowship and they can drive you through the various situations. Like this, you can do the SFIL in such situations. Here you can see that this is the case of opaque IOL. While doing the surgery itself, you can come out with the bag and should be prepared to do the SFIOL itself. These are the commitments of the IOL surgeons to put the IOL in any scenario. You can see that they have put the multifocals in the vitreous loss also, and posterior chamber lenses in the anterior chamber, and somehow some people have put the 2 lenses also, but they are committed to the IOL itself. But you should know that your limitations and should not touch such types of cases. Here in the trauma cases also, there are various types of additional pathologies which should be taken care by the VR surgeons. While doing, you create such types of tiers, and they should be managed by the VR surgeons only. There is a one thumb rule which I have learned during my vitreoretinal fellowship, is that first you should do the thorough vitrectomy and then do the lens removals or IOL explantation, which is not by doing the anterior vitrectomy only, where you are keeping and leaving lots of vitreous behind. If you are leaving lots of vitreous behind, then this can lead to the PVD induction and creates a breaks and retinal detachment, as well as it is a source of lots of vitreous and debris remaining, can cause the cystoid macular edema, ERMs, macular holes, and if you are not able to do the good scleral tunnels or plaques, then they can lead to the infections. Here you can see that one of the case where the scleral flaps were not done good, and the infection has been occurred. You can see the plug and underlying the Gore-Tex suture is exposed, which we have to cover it with the scleral patch graft later on. So in a nutshell, that any procedure requires lots of training to excel. For phaco itself, you need 100 to 200 surgeries to be done, while SFIOL also requires lots of training, and a general ophthalmologist which is having thousands of phaco surgeries is having less exposure to the SFIOL, and they will not be excel to the greatest results. This is how we can do it, and you should be very generous and sporty to send the such cases to the VR surgeons. This is for my next speaker, Dr. Shagun Singh, that ये सबसे जीवन का बड़ा सत्य है कि अपना काम से काम रखना दुनिया का सबसे मुश्किल काम है, फिर भी ये करना पड़ता है. Thank you very much for kind listening.
Love the way you kept saying, you do this, you do that. I took the you to be us, the poor anterior segment surgeons, and thank you so much for giving us that wake-up call, that wake up and apne kaam se kaam rakho. Thank you so much. Right, so to counter it, we needed experience. I think there was that was a all-out open attack on the anterior segment surgeons. So to counter that, we needed 28 years of experience, which Dr. Shagun Singh has, coming in from Amritsar, Punjab, speaking against the motion. Sir, your time would start now.
So am I audible?
Absolutely,
yes, sir. Yes, very much.
So thank you. I really don't believe what my partner has said. SFL should not be the only preview of the posterior segment surgeon. As long as good anterior vitrectomy has been done, SFIOL can be safely placed by surgeon. Depends on surgeon's choice of procedures, expertise, patient selections. There are definitely the two main issues which we need to take care of: is the management of the anterior vitreous and low intraocular pressure, which is going to be faced during this presentation. The pars plana vitrectomy versus limbal or a corneal incision, we just need to manage anterior vitreous phase, clearance of pupil and retropupillary area. In hands of any experienced anterior segment surgeon, anterior vitrectomy is as safe as pars plana vitrectomy. The second is the IOP. Easily available AC maintainer with a well-sealed mechanism keep pushing the iris and vitreous down. Anterior segment surgeons are more familiar to use this in their own routine cataract procedures. There are few studies which say the outcome of the visual acuity is almost equal in both, though there is a more chances of a myopic shift with the patient with the pars plana vitrectomy. So there are the references. I'm going to share one video which all of us would see and understand that this is not only the preview of vitreoretinal surgeon. So this is a PKP with scleral fixation IOL. As you see, we have already created a tunnel, the 26 gauge needle, taking that corneal button, entering the anterior chamber, the side port. You go with the needle within the closed chamber. This is IOL flange, which I'm going to share with you all. So you fix the IOL, push this in space. You make the knobs and bury that in the tunnel. It's done. Then you can complete the remaining procedure. Sorry. Just once you have completed the PKP, so take care of the anterior vitreous by anterior vitrectomy, or otherwise you ensure the capsule is well in place. For stay sutures. Sorry for the hitch. In fact, I was trying to push it fast because of the time constraints. In fact, I had two other procedures to show that I would not do now. You make the anterior chamber deep air to ensure the AC is clear, bury the sutures, and the procedure is completed. And there are n number of paper which says PKP, different corneal procedure has been done with the scleral fixation IOL. So SFIOL should not be the only domain of retina surgery, it should be the domain of both. Thank you.
Thank you very much, sir. So there is
you,
no
sir.
doubt about the fact that cataract surgeons today have incorporated SFIOL in their armamentarium so that they do not have to refer their complicated cases. But the question that we want solved in this forum is, what is the correct thing to do? An SFIOL or a glued IOL with an anterior vitrectomy, as an anterior segment surgeon would do, versus an SFIOL with a proper pars plana vitrectomy. What are the pros and cons? And to discuss this, we have a vitreoretina surgeon with more than 27 years of experience, Dr. Gajendra Chawla. So what is your opinion on this?
Thank you, Sneha. Thank you both speakers for putting their points very nicely and showing various aspects. Yes, as far as concern of SFIOL is concerned, it can be depend on what the situation you are dealing with. If, as Dr. Manoj has shown, so many number of patient where the nucleus drop or then definitely you have to go for a full vitrectomy. You have to go posterior vitrectomy and then to manage that posterior segment. But if suppose the surgery has been done somewhere else and it is only the PCR, or there is some you don't have a capsular support on the table and you can do a good anterior vitrectomy, then probably anterior segment surgeon also can do that. And especially with the Yamane technique, which is now coming up, it is having a relatively shorter curve to learn on. But if you are going for a proper, you should manage the complication. You should be trained enough to manage the complication of that procedure itself. If you are planning for, suppose there is during you are suturing that suture or glued IOL, there is some problem with the retina or it dropped down, then you are handicapped. So in that situation, I believe the posterior segment surgeon is having its upper hand. So if it is a simple PCR on the table, you notice you can do a good anterior vitrectomy, that is must. Then with Yamane technique, anterior segment can also do, but still the upper hand will be from the posterior segment.
Thank you very much for that unbiased opinion, sir. We can move on to the next topic now.
Thank you very much, madam.
Absolutely. Before we do that, I must greet each and every speaker and panelist for the fact that we have stuck to very good timing. I think we are moving on just in time, and we expect to finish off in time and hand over the hall for the next session as well. Moving on to motion number 6, and this is going to be interesting, just like the flax thing. This is just a new old wine in a new bottle. So the debate has been long-standing. We have debated this for ages now. And the motion is SICS and not phaco is the need for Indian eyes. the two participants for this would be greeting each other whenever they meet, would be greeting each other by saying Khambagani, because both of them belong to Rajasthan. Speaking for the motion, coming in from Mount Abu, here is Dr. Sudhir Singh. His slide is visible. You are ready to go, sir. Your time starts now.
I'm going to speak in favor of MICS. The MICS for such cataracts in your screen are like comorbidities is the only way, whether it's Indian eyes or elsewhere around the globe. So subluxated cataract with granulopathy, this is my case, and done the SICS with CTR ring and all that, and patient is perfectly fine after that. For this, my friend may need phaco with Jepto, with something not femto, and all these things. So these things are not required at all. So let's see what Dr. David Chang said, and this is a particular paper published on the cataract and refractive surgery. I resort MICS for DENSAT cataract when I feel comorbidities such as all these may make phacoemulsification riskier procedure for endothelium and the posterior capsule. So it is a wonderful option to have in my surgical armatorium. Now, for these like intumescent cataract, we SICS a surgeon can do it so many cataract in a day without doing any hassle, and like a high end viscoelastic and all that. And this is the result. My friend would need it femto laser, Jepto laser, and all this. He can afford it, but most of India patient can't afford the cost of all these fancy gadgets, I would say. So this is again the nuclear cataract, and this is 656 after 4 days. So again, my friend would need this Femto and Jepto. Without that, he can't do anything. So now again, Dr. What Chang says, he concluded that many mature cataract in the population, most Western surgeon, and I would have much higher complication rate than with phacoemulsification than with the MICS. So this is published in an article and cataract refractive surgery. So cataract refractive surgery is not now is just like is a savior. It's also like cataract and refractive surgery. So you can plan your surgical incision and you can correct the toricity without without the toric IOS. So these are the normograms. Basically, we can plan it by simply planning the incisions at the different medians and different size of incisions. So again, there is a beautiful concept that manual cataract refractive surgery. By monofocal IOL, we can have multifocal vision. If we can plan the astigmatism by this way, then we can have them. This is the like I'm running. This is the like most of type of multiple astigmatism, so we can do that. So in short, I will say again the setup cost. For the machine cost, for SICS, you require 10,000 rupees. For phaco, you require minimum 15 to 60 lakhs. For capsulotomy machine, you require like 10 to 15 lakh, or like femto, you require in crores. So annual maintenance is also there. So what I say, MICS is a savior in the complicated cataract. It is also a manual refractive surgery, and it is zero setup cost, and MICS has zero recurrent cost. So I would say in the last, it is scientific, it is safe, it is economical, it is technically based surgery. It is not expensive technology dependent surgery. It does not need expensive machines and consumables. It can be done safely in all type cataract, and it can be done safely in all type of pupil. And that's all.
Thank you so much, Sudhir sir. We heard you say repeatedly during the deliberation, your friend is going to need something to pull off the results that you pulled off otherwise. So who exactly is your friend, sir?
My friend is my opponent, Dr. Pandey.
And what did we do not to become your friends and to become your foes?
Pardon, sir?
So what did we do
no,
not to become?
You are respectable friends. You are the
He's not a respectable.
No, he is my friend because he is the dear colleague from my state, and I usually meet him, and this, like we usually meet like this.
Absolutely,
दो
absolutely.
राजस्थानी को लड़वा रहे हैं. It's war between two Rajasthani. You are just putting some ghee in that.
Yes, absolutely. That's my job, sir, as the MC.
Yeah.
Suresh Pandey, sir, please start sharing your screen. Here comes from Kota, Rajasthan, Dr. Suresh Pandey. Sudhir, sir, said you don't need machines, you don't need equipments, you don't even need proper IOLs to produce the results that he can produce otherwise with the help of manual small incision cataract surgery. Dr. Suresh Pandey from Kota, Rajasthan, a very well-known phaco surgeon, is here to counter him. Dr. Pandey, your time starts now to do that all.
Thank you so much. Am I audible?
Yeah.
Absolutely,
yes.
Sir.
First of all, I would like to congratulate Dr. Sudhir for making it very clear that SICS is very excellent technique for some complicated cases, not for routine cataract cases. As you all know, the phaco surgery has underwent tremendous evolution, and phaco remains the gold standard technique, and it stood the test of time. We have seen the revolution in the the mobile phone industry, telephone industry. We have seen the revolution in the car. Once upon a time, there was a lot of crowd on the PC or STD, and now they are gone. So similarly, I want to bring it to your notice that the phacoemulsification and intraocular lens implantation, these are the two most important innovation done in the field of ophthalmic microsurgery by Dr. Harold Ridley and by Charles Kellman. And they stood the test of time because they are one of the most important technique for getting the excellent results. And we have the technology and tools to produce the wonderful outcome, even in difficult cases like small people, for example, hard cataract, for example, white cataract. We have capsular dyes, we have viscoelastics like sodium hyaluronate, cornadine sulfate based viscoelastic. We have the femto Zepto tools, but if you don't have the femto Zepto, you can achieve the capsular axis with 26 gauge needle. With some experience, this can be done. And the phacoemulsification, no more is contraindication in the hard cases right nowadays in the small people, because we can do the small people phacoemulsification with the Malugin ring, with the iris hooks, and we have the premium lenses to implant to achieve the best visual outcome in 6x6 cases. And Dr. Sudhir very nicely highlighted that about the SICS, but mind you that SICS is not without complication. When SICS is done without proper planning or with a novice surgeon, with a less experienced surgeon, you can see a lot of complications such as the wound gap, the corneal endothelial decompensation, the IOL decentration, the endophthalmitis because of the large incision size. The first important thing is that the world is moving towards the smaller and smaller incision. So the phaco is gold standard, and it has several advantages. It can be done into topical anesthesia, and it provides you very quick rehabilitation. The quick question we should ask that is this surgery can I prepare for my own eyes? And learning curve is true for SICS also. Post-effectiveness can be minimized by high volume surgeon, and not every cataract is hard or every people is small. So do it right for the first time. This is my take-home message. And I would like to summarize that as a surgeon, we should keep on evolving, think quality, think about the premium cases, and think do it right for the first time. We don't always get a second chance, and let us commit ourselves to give the best possible vision to our patients using the best possible technology. Thank you so much.
Thank you very much, sir. So we've had retina surgeons versus retina surgeons, retina versus cataract, and now we finally managed to divide cataract surgeons as well. So the entire world has moved on to phaco, but is SICS still indispensable for India? That is the question. And who better to answer that than one of the past presidents of the state chapter ISM SICS, Dr. Santosh Bhire, sir.
Thank you, Sneha, once again. And you are now truly doing divide and conquer of anterior segment surgeons. So you're dividing anterior segment surgeons into two parts. Basically, I echo sentiments of the great surgeon David Chang, and Dr. Sudhir Singh has made my job very simple. Whatever David Chang has said, same thing I also echo, the same sentiments. Whatever is best for the patient, we have to do. There should be no surgeon's ego. We have to give good results to the patient and we should not do harm. Our oath says that do no harm. So if you feel that a black cataract with compromised cornea and you want to do phaco, just because you are a great phaco surgeon, you have flax with you, but you are going to damage endothelium ultimately. But with SICS, which is a beautiful artistic surgery, you are going to give great results. So I think phaco is a technology and SICS is an art. So to become a comprehensive cataract surgeon, I repeat again, you should be expert in both the technologies, phaco as well as SICS. And we know that the almost 70 to 80% of population of India is a rural population. Most of the patients, they come late. They come in a state where the cataract is milky white or cataract is hard, grade 4 plus cataract. Even my good friend, Dr. Pandey, must also be getting many patients who are grade 4. And in his practice also, he must be performing SICS. I'm sure about it. But for the sake of debate, he has said that phaco, no doubt, both the technologies are good. So whatever is best for the patient, you should do it. And you should not do harm to the patient. That's it. Thanks again.
Very nicely summarized, sir. So I think we should move on to the next topic now.
Yes, we should. So topic number 7. Topic number 7 is, the motion is bilateral simultaneous cataract surgery. Bilateral simultaneous cataract surgery is not possible in the Indian scenario. Is not possible in the Indian scenario is the motion. Speaking for it, coming in from Nagpur, Maharashtra, is Dr. Gopal Arora. You ready, sir?
Is my screen visible, sir?
Absolutely, sir. Go on.
Okay, a very good afternoon, and thanks to the AIS for giving me this opportunity. To begin with my presentation, the first thing I would like to ask my dear friend, are you serious? Are we debating this? Well, if you are, let's move ahead. Have we heard of this terminology called bilateral endophthalmitis? If not, believe me, the books on cataract surgery will have this in the top of the list as bilateral endophthalmitis. If this is going to be the norms for cataract surgery, that is bilateral simultaneous cataract surgery, and the tagline remains in Indian scenario. This is going to be one of the dreaded complications which everyone is going to be aware of. Have you not heard of these paper cuttings that are going into different vitrectomies or losing sight? And it's these paper cuttings and news are going to be flooded if that norm is going to be advocated that bilateral cataract surgery should be the norm in future. Let us take this again. In spite of the best efforts, in spite of doing the best A-scan, we do have refractive surprises. And believe me, my dear friend, who's such an expert cataract surgeon, I would not say 612, 6'9". He has the capability of doing a 6'6" part visual acuity patient for a cataract surgery because he's such an expert. And believe me, forget about endophthalmitis, just a small vitreous reaction and that 6'6" part patient going into 6'9" or 6'12", what are you going to explain? So it's better that we do sequentially. And let's talk of this Indian scenario. The surgeons doesn't scrub between the cases. Assistant does not scrub between the cases. OT fumigation is not done. Same machine and same equipments are used. Do the entire trolleys change between the surgeries? Even if we go for the simultaneous cataract surgeries, we might even have to shift the OT, which is not possible in Indian scenario. And look at if we have to go in for the camps, how are we going to counsel the patients to go for cataract surgery in a simultaneous way? Well, I am with my dear friend. If there are situations where you have to do for a pediatric cataract, bilateral hypermature cataract, or in patients who stay about 300, 400 kilometers away, we might even think of doing that, but not for all patients. Now, the big question which I would like to ask my dear friend, what if you need to operate on your parents or dear ones? Would you still prefer the bilateral cataract surgery, or would you wait for 24 to 48 hours and see the results in one eye and then go ahead with the second eye? So my point is safety first. You should think before you act. Thank you.
Thank you so much, sir. Point taken. I think it had more logic to it than anything else. Thank you so much for the presentation. To counter him, Here comes a man from Mumbai, Maharashtra, and is backed by one of the richest prodigies the ophthalmic sector has seen in India. Welcome, Dr. Cyrus Mehta, to center stage, and your thoughts against this very motion, against Dr. Gopal. If you're ready, sir, your time starts now.
Yeah. So see, this is my bedroom, and can you all hear me?
Absolutely, sir. Loud and clear.
Yeah, yeah. You can see that behind is the Terminator.
The old one, sir.
Yeah, so this poor fellow has had unilateral cataract surgery. You see now how bad he's looking. If he had had bilateral cataract surgeries, both his eyes would have looked the same. Okay, so now let's go to the talk. See, you know, bilateral simultaneous cataract surgery is not possible in the Indian scenario. Really? Are we so bad that we cannot shift our OT, or we don't have an assistant who will scrub up between two eyes? Absolutely not. Assistant has to scrub between two eyes, has to change the gown and gloves. He cannot be cleaning his hands with spirit as if this is a bhaji mandi and then just going from one person to the other. Maybe when we trained 25 years ago, that was the norm in some gown and all. You cannot do that stuff in any kind of metro today, because you will get caught. Eventually, you'll get some infections, and that will be the end of your practice. Immediate sequential bilateral cataract surgery, ISBCS, is the next big thing in ophthalmology. Given a choice, no patient wants to go back and forth to the OR twice. Neither would I. Why do patients select unilateral cataract surgery? Ignorance, fear. When cars first ran on the road, a person in front of it ran waving a flag to warn people. Family doesn't want, family is not ophthalmologists, so they really are not equipped to make such decisions. Conventional wisdom. As we know in science, there's no such thing as conventional wisdom. After 5 years, everything changes. We are taught if you do ISBCS, you may get double the complications like CME, end-off, TAS, and refractive surprise. But if you see a literature review, you will find here that bilateral, over thousands of cases, had much less complications than the unilateral. And this was end-off, corneal edema, PC rent, RD, etc. I've not had a single case of bilateral end-off or bilateral TAS in 20,000 cataracts over 15 years. I find that patients adapt to multifocals far better if the patient has had bilateral cataract surgery. Shri Ganesh studied this 4 years back and presented this actually at one of our landmark meetings at ESCRS. And he found that his bilateral cataract surgery was better than his unilateral. A literature review from 2002 over the years finds that bilateral cataract surgery patients do better than unilateral, especially with multifocal lenses, and no increase in complications. This is this month's ESCRS magazine Eurotimes, and the editorial is bilateral cataract surgery. And the take-home message, as he writes here, the president of ESCRS, he says that ISBCS allows comparable safety and effectiveness, and they studied this over 1,000 patients in the Netherlands. Of course, in COVID times, having the patient come once less and rather 4 or 5 times less to you is far superior. And there are no comparing the unoperated eye to a trifocal. If you are in the trifocal business like I am, and you have a patient with a trifocal lens and the other eye is 6x6, sometimes they'll see better with the unoperated eye. Then what answer should you give them? But if you put trifocals in both the eyes, now they never have the chance to compare. The boogeyman of bilateral endophthalmitis is unfounded. I have had endophs, but never bilaterally, in more than 25,000 surgeries. ISBCS is the new mantra, and there are plenty of references here for us to look at. So in the Indian scenario, it's not really very valid point, because if you actually go to see, we are as good as the West, if not better now.
Thank you so much, sir. So that was a very high-tech discussion for a very high-tech topic. We have a quick comment from Dr. Anand Parthasarathy. Bilateral sequential surgeries, is it not possible in India, or is it the requirement for India? What is your opinion, sir?
Very, very valid in terms of what they mentioned. Whether, and the real answer, I think, lies in the surgeon's own mind. If you would get it done for yourself, then you would be comfortable doing it for other people. If you ask me what my present position is, I would prefer refractive accuracy over anything else. And when you're dealing with high premium patients, which I'm sure all of us do have, getting refractive accuracy is extremely important. 1 in 1,000 patient who has bilateral trifocal implantation has a refractive error of plus or minus 1. You would have to take them back for treatment. And I feel with doing resurgeries bilaterally is tough. But points are well taken from what Dr. Cyrus says in terms of the convenience of patients, and there is no denying that. There have been enough number of studies published showing the validity. I do know of surgeons in India who do it quite routinely, even down south. And what you're correct, if you treat it as 2 different surgeries, and that has been done for ICL surgery, where you scrub differently, your viscoelastic is different, your saline is different, your batch of the autoclave is different, then I feel the level of safety you definitely increase to a stage where you consider it as 2 different surgeries. So in terms of getting your infection control clear, you're getting your refractive accuracy good, it is a viable option. Whether I would do it at this stage where for me refractive accuracy is important, I would be the person sitting on the fence.
Very true. So, so what I understood from this is, Dr. Cyrus says the 90s terminator looks bad because one of the eyes has been operated. Dr. Gopal says if one of the eyes is operated and the terminator looks bad, he might be looking bad for the eye which has been operated. So let's not give him both the eyes red and both the eyes looking ugly. So both the points very well taken. Thank you so much for summarizing it nicely, Dr. Anand. We move on to the last topic of the debate session here, which is dilate every cataract patient before cataract surgery. I understand the motion to be dilate every cataract patient in the OPD before subjecting him to cataract surgery is the motion. Speaking for it from Ludhiana, Punjab, here comes Dr. Dinesh Garg. Dinesh sir, please start sharing your screen. We are ready when you are. Go on to the presentation mode, sir.
Can you see?
Yeah, of course, we are in transition. Yes, now we can see the slideshow, sir. The clock starts ticking for you now.
So this is like dilate every cataract patient preoperatively before you take up cataract surgery. We as ophthalmologists and cataract surgeons, we are all obsessed with cataract surgery or surgery either to do bilaterally, who will do, who should do, who should deal with the complications. But most important is what the patient wants. And he wants excellent surgery 6/6 vision. So I want that he should be dilated preoperatively and we should know what we are doing. So I am for dilating every cataract patient before cataract surgery in the preoperative checkup. I don't have any financial disclosures to make. So the outcome of IUL implantation, even after the excellent bilateral surgery done by Dr. Cyrus, is dependent on the health and function of the macula. Every patient these days expects 6/6. So in-depth examination of the eye is a must before surgery. So let me start by saying this, that the time spent preoperatively on pupillary dilatation is the time well spent, whether you are a high volume surgeon, premium IUL cataract surgeon, whether you are working in a charitable hospital, corporate hospital, solo practice or group practice. Satisfied patient is our best advertisement. And that's long way or in a long innings into the profession. A comprehensive clinical examination, including dilated fundus examination, is a must, because in preoperative phase, we are planning to do cataract. Then intraoperatively, we execute that, and postoperatively, we deliver the services which we are hired to do or which we are being paid for. And the quality of that delivery is going to matter throughout life for that particular patient. So it gives a very useful insight into the expected postoperative results, like how the pupil is going to behave during surgery, what will be the maximum pupillary dilatation, are there any synechia, will you need any iris hooks or expanders, and how much cataract hardness is there, what is the type of cataract, is there any subluxation, what is the health of the zonules, is there any phacogenesis, pseudo-exfoliation. All these things need to be ruled out beforehand in the planning stage before we go ahead and venture into doing cataract surgery, execute, and before we land up in any such kind of a trouble, before we say that we have implanted a multifocal IOL, but you can't see because you have a ARMD or you have some other disease at the retina or a macular scar. So I'm sorry, I'm not going to do that. So you can have visual surprises, you can have problems, you can have uveitis. All these things will trouble you throughout. The patient will keep coming back to you. You can prevent retinal detachment if you are able to preoperatively locate any breaks or holes or lattice and treat it accordingly if needed, if you are going to have any intraoperative difficulties. So friends, I would say it is better to be safe than to later on. If you miss any pre-existing condition, the patient is going to put it onto you and say that, oh, cataract surgery has done this to my eye. If you have diabetic retinopathy preoperatively and you have not assessed, you have not treated, and the CME increases, it's all going to come onto you. If there is uveitis, you have to plan how stable it is. If there is ARMD, you have to treat or at least time your surgery and avoid a multifocal lens. So the take-home message in this is, we are in the service sector and eye care is an integrated part of that. A happy and a satisfied customer is our best advertisement for the long term. We must promise less and deliver more. Quality of service delivery is going to be the key. Better safe than saying sorry later on. So you must dilate all the patients coming to SICS or FACO or flats or whatever you want to. Thanks.
Thank you so much. Thank you so much, Dr. Dinesh. I think the crux of the matter is that it takes some time for the people to get dilated, and perhaps it's not very well suited for centers which are really high volume. Let's call upon a speaker who speaks against this motion, and he belongs to one of the highest volume cataract surgeons in the country. And I feel a sense of nostalgia when I invite him onto the center stage because he belongs to my alma mater. Coming in from Aravind Eye Hospital, Madurai, we have Dr. Madhusekhar, who would be speaking against the motion and would be the last speaker of the debate session. Dr. Madhusekhar, can you please start sharing your screen?
Thank you, sir, for giving me opportunity. So I am not completely disagreeing my opponent about dilatation, but why to dilate every patient before cataract surgery? Is my slide visible, sir?
Absolutely, sir.
Yes, sir. So in today's world, cataract surgery is performed in a daycare procedure with advent of higher in this phaco machine and higher in the microscope, and it can be done in less than 10 minutes. So why to dilate every patient and make them wait for more than 45 minutes for their pre-op workup? And especially in like as you told that in our high volume setup where so many patients walks in for cataract surgery, around more than 1,000 patients come for every day for cataract surgery. So it is very time consuming. So especially in this COVID pandemic where the space management and to prevent overcrowding, when you dilate every patient, you will not able to maintain this space. You cannot manage your space management. And certain condition like angle closure glaucoma, intermission cataract, where it is contraindicated to dilate preoperatively, but we get good result post-operatively also. Sometimes if you are using dilating drops with phenylephrine, it can cause adverse reaction in hypertensive and cardiac patient, and sometimes it will be fatal for them. Few patients are allergic to this dilating drops, and sometimes we see on the day of surgery there is chemosis, congestion, discharge, and it can lead to unnecessary postponement of surgery. And as we know that any preoperative drops, if we apply dilating drops or any local anesthesia, it can cause punctate keratopathy, and it can lead to inaccurate IOL power calculation. Sometimes there will be fixation loss after dilatation, and it can lead to poor localization of fovea and ultrasound or optical biometry. And few studies have shown that if you dilate every patient on previous day of surgery, it causes pupillary fatigue, and it can lead to unnecessary waiting time to fully dilate patient on the day of surgery. And sometimes it makes it difficult to select correct patient, appropriate patient for multifocal IOL. Sometimes if people dilate, you will not able to choose it, whether people was very small or it was mid dilated. And sometimes there is chances of error in measurement of angle alpha and kappa, which is very important in choosing this type of multifocal IOL. And patient-related factor. If you dilate every patient, it is difficult for them to go back to the work, and it can cause impede driving. Sometimes it is known cause of stinging and burning sensation, dry mouth, and headache. And some of the clinical situations like phacodonosis, iridodonosis, and VI can be better appreciated when people is in undilated stage. Some of the optic nerve disorder, which can be assessed only when you do the pupillary reaction. And fundus evaluation. Many patients with dense cataract, you cannot evaluate the fundus preoperatively. You have to do it after postoperatively. And many fundus cameras and other machines have came, which you can see the fundus in undilated stage also. Thank you.
Thank you so much, sir. So one of the most controversial topics of this debate, because no one would want to take it up, I really want to thank Madhushekhar sir for being very, very sporting and taking up this topic. So I think everyone agrees that retina evaluation is a must before every cataract surgery. But the question here is how much is enough, or how much is possible? Is only seeing the posterior pole enough, or do you have to see the periphery in all the cases, or to do a 360-degree scleral depression in every case? How much is enough? So take a very quick comment on this from Dr. K.S. Kumar, sir. You need to tell us, sir, what is ideal and what at least is a must to do before every cataract surgery.
Yeah, unfortunately, we had to make this disclaimer at the beginning of the debate, but better late than never. Now, there is no take, if at all there are anybody watching this, I doubt very much, on a Sunday afternoon on the fourth day of the conference, but if there are any, it's very important to make it clear to them that there is really no take-home messages in these debates, irrespective of how vehement, how dogmatic, or how melodramatic each speaker says. Much can be said about both sides. These are merely for enjoyment as a debate, and decide for yourself what needs to be done. But for this particular topic, I would like to say that it's really a no-brainer. And as you rightly congratulated Dr. Madhushekhar for taking it up, it's very important for us as ophthalmologists not to become cataract smiths, if I might call it so. You need to be aware that there is a portion of the eye beyond, and which is why the debate on cataract surgeons also doing a little bit of medical retina is very important, because then it will widen their horizon and know that there is land beyond the cataract. So that is very, very important. And contraindications to dilation should not become the norm. They are merely the exceptions. They are not the norm. And it's like saying, high volume surgeons not dilating is like saying, it's almost like saying that I have a high volume, high-end car, and therefore I don't need to fuel it. Irrespective of which car you have, you need to fuel it. And irrespective of the volumes that you have, you need to do justice to each patient. So there is no question, there can be no question about the fact that each patient needs to be dilated. Having said that, if you want to hair split the topic, of course, yes, you may not want to dilate the pupil the day before because of pupillary fatigue, and the pupil may not dilate on the day of surgery. That's probably the only situation where you don't dilate before cataract surgery.
Thank you, sir. I think we need to end this session. We are running late because the next session is already supposed to start. So wonderful session. Thanks a lot.
Thank you, everybody. Thank you, all the speakers and panelists.
Wonderfully done, Anurag and Sneha. You were
Thank you
so much, sir.
So good, Anurag. Good, Dr. Anurag, Dr. Sneha. A lot of praises I see in the chat box.